Assalamualaikum warahmatullahi wabarakatuh. I am Nakilah binti Nawi from OUM Kota Baru. Okay, today I will present my case study about diabetic ketoacidosis. Okay, first is introduction. Diabetes mellitus can be defined as a group metabolic disease in which the person has high blood glucose because insulin production is inadequate or because the body cells do not respond properly to insulin or both. Patients with high blood sugar will typically experience polyuria, they will polydipsia, hungry, and polyphagia. Diabetic ketoacidosis, also we known as DKA, is an acute metabolic complication of diabetic characterized by hyperglycemia, hyperketonemia, and metabolic acidosis. DKA is most common among patients with DM and develop when insulin levels are insufficient to meet the body basic metabolic requirement. Okay, there are five main criteria of DKA. First is capillary blood glucose more than 11 mmol, capillary ketones more than 3 mmol, or urine ketone more than 2 plus, and venous pH below 7.3, and or bicarbonate under 15 mmol. Okay. The sign and symptom, no, DKA ni can cause nausea, vomiting and abdominal pain and can progress to cerebral edema, coma and death. Diabetic ketoacidosis is among the most serious acute complication of diabetes. Okay. Okay, I will present about my patient that I have taken during my posting at emergency HRPZ. Patient name Miss F, age 52 years old, race Malay, gender female, weight on admission 50 kilo, date of admission 18 December 2020. Okay, chief complaint with Miss F, 50 years old, Malay, housewife, presenting to ED Hospital Raja Perempuan Zainab 2 Kota Baru, complaint of lethargy and fever for 3 days. She claims having fever for 3 days associated with lethargy, chill, rigor, and also poor oral intake for 3 days. She also claimed had vomiting for about 5 times per day for 2 days. She claimed having suprapubic pain with UTI symptoms such as dysuria about 3 days and already seek a treatment for UTI from nearest private clinic at her home. There was no history of leg swelling, no UTI symptom, no loose stool, and no SOB. Past medical illness. This patient, known case of diabetic mellitus, almost 10 years. She on OHA, oral hyperglycemic agent, and insulin therapy, but not proper compliant to the medication. Take treatment at KK Pengkalan Cepa. History of warded 2 times before this. Okay, she also known case of hyperlipidemia since 2015 and on simvastatin 20 mg/on. Okay. Past surgical history, no past surgical intervention done previously. Social history, she is a housewife, no taking alcohol or no smoking, deny for taking any traditional drug. Family history, mother of 4 children, 2 sons and 2 daughter. Her husband worked as a taxi driver area Kota Baru. Family history of DM, her father have DM before this, and poor family support since 2 of her children is OKU, orang kurang upaya. Medication history and allergy, no allergic to food or any medication. She is on subcute mixed 14 unit BD, subcute insulatat 12 unit ON, metformin 1 gram BD, simvastatin 20 mg ON. She take treatment at KK Pengkalan Cepa, but she claims not proper compliant to her medication and always miss her insulin injection. Also have poor diet control. Not taking her insulin injection about 2 weeks. Okay. Physical examination during admission is a vital sign. Blood pressure is 130/80. Pulse rate 110 beats per minute. Respiratory rate 22 per minute. Temperature 38/10, 38.2 Celsius. SpO2 95% under room air. Glucometer, high index and pain score 4/10. Cardiovascular symptom, inspection, percussion, palpitation and auscultation is normal. Abdominal normal. Gastrointestinal tract, inspection, percussion, palpitation, auscultation is normal. Neurological symptom, moving all limbs, reflex normal, pupil bilaterally reactive and non-negative nerve. Investigation that have done to this patient is FBC and capillary ketones. FBC is to check for any increase in white blood cell, and to relevantnya to find any sign of infection that can cause of sepsis. The white blood cell is increased, show there is a source of infection in this patient, and capillary ketone present more than 3 in DKA patient. This is a result of the FBC and capillary tone of this patient. White blood cell is 21.3, high white blood cell. HB is 12.1, is a normal range. Platelet and hematocrit is in the normal range, but capillary ketone is high, more than 3, is 4.1. Venous blood pressure is to find out metabolic status and the result of the patient before and the post treatment of KCL. The first reading of VBG show that there is a acidotic pH. The PCO2 is slightly lower than normal range and the sodium bicarbonate is low, which acidotic. The result of this VBG is metabolic acidosis with concurrent respiratory acidosis, as the expected PCO2 should be in between 30 to 32. Okay, this patient also we take BUS to look for any electrolyte imbalance and to observe for potassium level before and after potassium given to the patient. The result BUS for this patient is normal. This is a first reading and the second reading after the post-treatment of DKA. Okay, we can see that the potassium is increased from 4.1 to 4.6 after the post-treatment of KCL. Okay, and next is the urine FEME. The result of urine FEME is abnormal, where the leukocyte 2+, blood 1+, ketone 3+, glucose 4+. The urine result show there is a positive finding. The leukocyte 2+ show that there is a UTI, urinary tract infection. There is a blood present, maybe indicate that patient having UTI. The ketone is moderate, show positive finding for dehydration and also DKA, as well as there is a glucose in the urine. Next is the chest X-ray. Chest X-ray is done to the patient to check for lung problem and look at size of the heart. Chest X-ray for this patient is a normal, and ECG done to the patient. ECG is to record the electrical activity of the heart. The result is patient having normal sinus tachycardia, where is the heart rate is 110 per minute, but no ischemic changes done to this patient. Differential diagnosis to the patient is a diabetic ketone acidosis, hyperosmolar non-ketotic coma, and a sepsis. And the last is lactic acidosis. This patient not diagnosed with hyperosmolar non-ketotic coma even though the blood glucose is high. There is no increase in serum osmolality and also increase in bicarbonate in this patient. Next is the differential diagnosis of this case. Differential diagnosis is a diabetic ketoacidosis (DKA), hyperosmolanan ketotic coma, sepsis, and lactic acidosis. Okay, this patient not diagnosed with hyperosmolar non-ketotic coma even though the blood glucose is high. There is no increase in serum osmolality and also increase in bicarbonate in this patient. She also not given for lactic acidosis because the serum lactic reading was in a normal range even though the clinical presentation of this patient suggests for lactic acidosis. Okay, so the diagnosis for this patient is DKA secondary to the urosepsis. Okay, management to this patient is DRABC, danger response airway breathing circulation. Danger is put patient on bed and lock, star wear first layer PPE, glove, mask and apron. Response assess patient level of consciousness. GCS, this patient is full, 15/15. Airway was pattern, no obstruction, no foreign body. Patient able to talk, prone up patient, semi-fallen position. Breathing, patient respiration rate 22 per minute. SpO2 and arrival 95% under room air. Circulation, take vital sign, BP 180, pulse rate 110 minutes per minute, respiration rate 22 per minute, SpO2 95% under room air, temperature 38.3, dye scan is high index. Immediate treatment for this patient at ED, give oxygen nasopron 3 liter to this patient and attach cardiac monitor to the patient. After that, monitor vital sign, insert IV granula using large bore cannula and blood investigation taken. Give IV drip normal saline 1 liter for first 30 minutes and according to the CPG DM type 2, initial fluid given is depend to the systolic BP on the patient during admission. If systolic BP is below 90, give 500 of saline solution for 10 to 15 minutes. Once systolic BP more than 90, give 1 liter of saline over 1 hour. But if systolic BP on admission is is more than 90, give 1 liter of saline for 1 hour. Okay. After that is the K level of this patient during admission is 4.1. So potassium addition 20 to 30 mmol potassium in each liter of IV fluid given to this patient. To maintain serum potassium at 4 to 5 mmol and repeat use 1 to 2 hours. After that, continue fluid replacement via infusion pump. 1 liter saline with KCl on next 2 hours. 1 liter of saline with KCl next 4 hours and 1 liter of saline with KCl over 6 to 8 hours. Addition of the potassium is likely to be required in the second liter of fluid, especially if baseline potassium below than 5 mmol and to maintain potassium between 4 to 5 mmol. Insulin infusion should be stopped if potassium is decreased below than 3.5 mmol. KCl is not needed if the potassium more than 5.1 mmol. Okay. Sacubitril 12 units start given to the patient. Start IV insulin infusion pump. 50 ml per hour. IV cefuroxime 1.5 grams stat as antibiotic for UTI infection. IV ranitidine 50 milligrams stat as a GI protectant to the patient. Take PCN 1 gram as an antipyretic because patient have fever. Monitor glucose hourly and repeat glucose after sacubitril. Repeat glucose is 16.5 mmol. No bicarbonate are given to the patient because the pH is more than 6.9. If pH below than 6.9, add 15 ml of natrium to 200 ml D15 over 1 hour. Repeat VBG every 1 to 2 hours until pH is more than 7. Insert CBD to the patient to monitor urine output of the patient since the patient is on KCL, and to withhold potassium replacement if no urine output. Okay, hourly capillary plasma glucose until it reach maintenance level of 8 mmol. Vital sign including temperature is repeat because patient have fever. Continue IV insulin infusion until resolution of DKA. Resolution is defined as a pH more than 7.3. Monitor and adjust insulin dose accordingly. This patient is planned to admit to the medical ward. Okay, as a conclusion, according to management of the DKA and Malaysian CPG management of DM edition 2020, the principle of management DKA is correction of dehydration, correction of electrolyte imbalance, insulin therapy, treatment of precipitating factor, and prevention of complication. Diabetic ketoacidosis (DKA) has high mortality rate if unrecognized. The overall mortality is 5% in the elderly has been reported. Mortality in patients with DKA is frequently related to the underlying etiological precipitant rather than the metabolic sequence of hyperglycemia or ketoacidosis. There is no delay treatment given to the patient. Good and complete history taking and also investigation help in determine the correct diagnosis and also suggest the correct management to this patient. Okay. Okay, that's all from me. Thank you.